This is Roger Green, host of the Surfing the Mesh Tsunami podcast. This week we're offering 5 conversations from episode 15, our review of the SLD Think Tank 2024, with co-hosts Jeff Lazarus and Jörn Schottenberg, and participants Maja Thiele and Mike Betel. Plus, from the vault, a conversation from our review of INCBCN 2023, the predecessor meeting to this year's Think Tank. This conversation from SLD Think Tank 2024 focuses largely on ways to improve delivery of screening services to patients. As it starts, Mike Betel transitions from a broader discussion of prevention to note that there are 94 FibroScan devices for all of Canada, and even these 94 are severely underutilized. Maja Thiele states that having a drug in the market will motivate stakeholders throughout the system to screen more aggressively because they feel that having an approved drug will enable them to help patients better. Louise Campbell asks whether the vision around utilizing FibroScan better included more creative approaches to the site of delivery rather than simply getting more machines. This leads the group to discuss what will be necessary to improve utilization of the machines. Specifically, Mike Betel asks who will coach allied health providers and physicians to use NITs, in this case specifically FibroScan, as a way to open broader conversations on liver health with patients. This discussion demonstrates how much a small-ish group of 100 can accomplish when working with passion and focus inside an innovative meeting design. There's a lot to unpack here, so just sit back, listen, learn, absorb, enjoy, and when you're done, check out and perhaps contribute to the memorial page on our LinkedIn discussion group.
Mike Betel.
I do recall that someone from the audience from Canada had raised the challenge of assessment with the number of FibroScans that are available here, and there was only 94 in the entire country. And so assessment is going to be a challenge, and also just patients having to pay for some of the very basic, ASD, for example, tests. And so those are 2 huge challenges that have to be overcome.
Jeffrey Lazarus.
Exactly. I remember that number of 94 and thinking how vast Canada is. I don't even think there are any in France, which is interesting with EchoSense being a French company. But, we really tried to say, in a way, we have the tools, right? We have NITs that are pretty accurate, especially when you combine them. We have a MASH-specific treatment, but also obesity and other drugs that can be used. And yet, very few people are identified. Very few people are being cared for. And that's where we tried to dream big. What do we need to do to double the diagnosis in 2 to 3 years? For example.
Maja Thiele.
But one thing that I think was mentioned a couple of times was also the stigma related to liver diseases in general and steatotic liver disease, obesity as well. And one of the added benefits of having a pharmaceutical intervention towards SLD is that it could actually improve the stigma. It could help raise awareness, but it could also help lower the barrier for patients to ask their GP and be more open in their discussion about detection of liver disease and potential treatment. So I think that's an added benefit of actually having a drug treatment, even though we for many years have been able to treat both MASLD and Med-ALD and ALD by targeting their risk factors. There still remains this kind of nihilistic approach that among many healthcare workers that, we can't do anything anyway, so why bother finding patients when they won't ever change their lifestyle, so I won't ever look for them. And I think this nihilistic approach can be changed, even though it's an expensive drug, just the fact that there is a drug, and this was also mentioned.
Jörn Schottenberg.
I fully agree. I think at so many levels, the availability of a pharmacological treatment is going to change how physicians practice and assess a disease, and this will get this up. For sure, screening is going to improve. I think we still have to do a lot of work in education. So Jeff, looking into the future, one of these years, we might go back to a larger educational event even. But having said that, I think there are many interesting questions we have to develop. And I felt that this year's think tank was really unique for that.
Louise Campbell.
I was just going to jump in on what you said, Mike, in the context of you commented on 94 FibroScans, for example, in Canada. Did the teams discuss actually how they're used and utilized? Because they should be doing something in the region of 470,000 scans. Are they doing that sort, or are we still talking about scans in a clinic in hepatology doing a couple of clinics a week? So being basically not utilized in the type of way that we now need to look at utilizing non-invasive techniques like FibroScan or the other mobile devices to maximize what they should be doing to help do the scanning and the screening. Because if we're saying that each one of those 95 scan machines, like I can find in the UK, might be doing 500 scans per year, that is an underutilized resource that we are not doing behaving in the rest way because we're pocketed into the old way of thinking that we have to deliver this from a hepatology clinic with a nurse once a week in this location or this location. So we don't get the value and we don't get the reach. So did you look at how many and ways to enable that within the NITs?
Yeah, I think you know the answer, Louise. I mean, there's massive underutilization. That's the irony. When I used to work in Copenhagen, we had a portable FibroScan that was used 1, sometimes 2 days a week. And there were all kinds of issues around transportation insurance. Could you bike with it? Like Maja and I would bike. We've also had our crashes. But how do you transport these things? The insurance, that's maybe an extreme example, but it takes a lot of logistics to maximize the use of any healthcare tool or diagnostic tool like that. And that effort is not being made. So, the irony is on the one hand, there's 94 FibroScans in Canada, which isn't enough, but then even those 94 aren't all necessarily being used enough. So it's how to get that balance, how to get that happening. There's studies going on, at least in Europe, about more and more using FibroScan in the community. It took us almost 1 year to get IRB approval to do that as a part of a study. We have another study with FibroScans in general practitioners' offices and primary care. And again, it's slow going. There's training. They have to make the time to use it. There can be reimbursement issues, not in this case because it's a study, but otherwise. So we need more of these imaging tools. And at the same time, we need to use more of the ones we have.
And maybe a way to coach the people who have the machines in the clinics on how to better utilize them. Because I also, and you're right, Louise, I can give you examples, which I won't do now, but of clinics that have them and are definitely not using them to capacity. They have lots of opportunities, but they're a little bit further out, a little bit more remote than some of the center areas. So I think it's about encouraging people to use what they have too. You're right.
Roger Green.
One of the many things Louise has taught me over the last 4+ years is that utilization here takes on two contexts. Number one is it getting used enough hours a week? And number two is, are we doing a good enough job of taking the lessons that you can learn from a scan and transmitting them to the patient while the patient is present so that you can actually turn it not into just here's a test, but here's a test, here's a result. Let's talk about what we're going to do about it. It seems to me that those are both issues in terms of optimal utilization of machinery. And I'm wondering if it's too early to talk about the second one because we're going to have base core underutilization, or do you really think we attack both of those at once?
Well, for my question, as you're asking those questions, is who's going to do the coaching? It's not like there's somebody assigned to that, right? So the clinicians sitting there with the machines that they paid for themselves in some cases and not using them to capacity as a charity. I mean, we had an event there as an example, and they worked with us on that, but that's just once. So there's a lot of other opportunities for sure for that. But I think the education piece is really important also. Louise does it every day, so she would be able to answer that for sure.
We use a different model, and this was what I was looking at when you were talking about the 94 scans. So we use a different model. If you need FibroScan, we will get it to you with the practitioners, and you can have your 10,000 scans per machine or 5,000 scans per machine. It's a different model, so we're coached, we do it. So the reason we developed this was I've worked in that system in healthcare whereby the machines are underutilized. We don't have enough resources. So actually create something that's skilled that just provides the resources. From listening to Jeff and Maja and that earlier, it was about where these solutions were coming from and this whole different approach to taking out something different. If you look at the ECHO program, hepatitis C, and how that developed into bespoke, difficult to treat communities, and to take those skill sets. And I think that was what Maja, you were alluding to earlier, is the learning from that and being able to stand by a board and listen to other people's work within that. Jennifer Selpin, a nurse practitioner in the US, took out a little mobile van and started scanning in different parts in hard to reach communities, for example. These are pocket projects. And I think we can do that with NITs. We've discussed with Stephen on the podcast before, the little cassettes that you can have with blood tests for going into Africa and more hard to reach communities with different ways for liver. And that was the sense that I got from listening to Maja, Jeff, and yourself about what the didactic part of these conversations was really giving, which was exciting to listen to what was going on earlier.
Thanks, Louise. Now we're diving into the weeds, but you get a feel for what the think tank was like. So it was 100 people trying to address particular problems. And a lot of it is operational, logistics, health systems, preparedness. Do we need better NITs, better sensitivity and specificity? specificity? Sure. But even with what we have, we're not getting, the bang for the buck, out of them. So that's why the think tank is here to stay, Jörn, right?
Yes.
And I think with the open space, this is where you could gather around Maja or Jörn or someone else and be 2 people or 3 people or 33 people and discuss the issue as long as you want it. I think if we do longer open space sessions, we can have really specific questions where we want to find, solutions. So, what in the business world would be like, minimum viable products and so on, but just, really dig in to answer some of this. And we don't get this opportunity at a lot of the bigger scientific conferences. So that's where the added value of this smaller, largely invitation only meeting fills a gap. It's a think tank, and the webinars throughout the year will bring up some of these issues, and we'll talk for 30, 40, 50 minutes again on a particular issue that emerged from the think tank that needs better addressing. So Michael, maybe we need to bring the Canadians and do a Canadian hour and talk about that and have Louise share her experience and the ECHO experience.
That would be really cool.
And so on and so forth. With whatever issues emerged, we've been thinking about it. Now we need to find solutions.
That would be really great. I just want to add something that Jeff is probably going to smile and Jörn too. And it has to do with what Maja said with diversity. And this was not an accident, but the percentage or the number of younger people there, because we get older, more and more people are younger. But the younger people that were there was fantastic because they were so interested and so engaged, right? So early career kind of people.
Thanks. We made a concerted effort. So some people come to hear the KOLs, to hear the experts who have 10, 20, 30 or more years of experience. So they were there. We had 29 faculty. We allowed 10 posters to come, and the presenters were there presenting their research. We allowed a couple people to invite very young investigators and interested parties to join. So we had a teenager, we had a 22-year-old in there, and they were great, telling us, what they were doing in a high school to raise awareness. And it was really invigorating for all of us across the age continuum without going into details.
So, Jeff, congratulations, by the way, on your 20,000 day celebration recently. We know exactly where you sit on that curve, plus minus a few days. But
someone said, how did you know? And I said, I've been counting, but obviously there's an online calculator. But ever since I saw the Nick Cave 20,000 Days documentary where he documented his 20,000th day on Earth, I was like, I gotta remember to celebrate that day because my birthday's in the summer, right? So the office is closed, and school was closed. I had to have my day. But then I mentioned it at the Turkish hepatology, and Manal said, well, today's my birthday. So of course she got the cake, but that's all right. I got a piece.
I'll get a cake for you, Jeff, next time.
Jeff, you couldn't have blown out 20,000 candles anyway. Go ahead, Jörn.
Yeah, 20,000 candles. That's a good one.
And now, back to Roger.
We hope you've enjoyed this recording. If you have any questions or comments about the content of this conversation or the entire episode, please put them in the review section of the page from which you downloaded this conversation, or send an email to me at questions@surfingmash.com. Next week, we plan to preview elements of the EASL Congress, which comes next month in Milan. Until then, stay safe, surf on. See you on the podcast. Bye-bye now.